right, this is chapter 34, part 2. We're beginning with obstructions of the urinary tract. I want to talk about hydronephrosis, which is this occurs when there is some type of obstruction of the normal flow of urine. You get a dilation of the renal pelvis and the ureters. That obstruction causes a backflow, basically. And we have a picture, you see here, hydronephrosis. You can see the back, you can see the renal calculus there, causing the causing the obstruction, and so you have a backflow into the kidneys. You have hydronephrosis. Um, Signs and symptoms: severe pain, signs and symptoms of kidney failure, and we will need a urologic exam and detailed X-rays. It's diagnosed with the urologic examinations and radiologic studies. Treatment may include a nephrostomy tube or a uteral stent. This basically will clear the obstruction. Nursing management includes post-operative care of the patient. We want to be monitoring for any hemorrhage and monitor the dressing. And again, when we have any kind of invasive procedure done on the kidneys are very vascular, so risk for hemorrhage is a priority to be monitoring for. And of course, we want to continue making sure we're implementing position changes, coughing, and deep breathing. This slide talks about nursing management of post-operative nephrectomy. So understand the care anytime a patient has surgery on their kidney. So we want to make sure we're monitoring the surgical incision. Again, hemorrhage is the high risk for these patients, so we want to make sure we're monitoring that. And you always want to be sure, if you go in and assess your patient's surgical dressing and there's blood on it, you want to mark that with a marker and date and time, and then come back and monitor to see if it changes at all. And remember, you never change the first dressing after surgery unless you have an order. You want to carefully assess the patient for any presence, for any drains present, or any tubes that may have been placed during surgery. And your focus, your priority is on maintaining urine flow through any catheters or tubes. We must always be monitoring for our tubes to be patent. Of course, you're going to monitor vital signs, monitor for any signs and symptoms of hemorrhage. If you have any, you notify the physician and monitor your patient for shock. Now, if you notice a dressing that has increased drainage on it, you can reinforce that dressing. You always want to let your physician know if you do that. And be sure, if there's any tubes or drains present, that you don't dislodge them when you reinforce your dressing. Continuing with our post-operative nephrectomy care, you want to position the patient according to the physician's orders, and that'll depend on what procedure, what type of procedure he did on the patient. So follow the orders. The movement will be painful to the patient, so you want to be sure you're teaching and helping the patient with turn, coughing, and deep breathing. And then monitor urinary output, especially from the opposite kidney. Not actually, you want to monitor from both. The opposite kidney in which the surgery occurred on, you want to be monitoring and making sure it's functioning, and you also want to monitor if any tubes are present in the affected kidney. That takes us to renal calculi. A renal stone is a urinary tract obstruction and leads to hydronephrosis, which we looked at on that diagram. And basically, these stones are made up of calcium salts, calcium phosphate, calcium oxalate, uric acid, cysteine, and bacteria. Um, Renal stones also can vary dependent on it can vary composition depending on their environment in which they form, whether it's acidic or alkaline. You have on table 34.2, page 794, four major types of renal stones. I'm going to move on to causes, understand the process of the disorder. Basically, you have supersaturations of urine with crystalloids in them that do not dissolve, and so that leads to stones developing. Urinary infections can produce bacteria and other debris that can lead to forming the stone. Not drinking enough fluid, having concentrated urine, or inadequate flushing of the urinary tract can lead to stones, and sluggish flow of urine. Uh, that may occur with bed rest and immobility. That can lead to stones. Certain substances in the urine can encourage formation of stones, and it's important for the patient to understand what type of stones their body produces. They can actually implement measures depending on what type of stone it is, certain measures to prevent the a stone, that particular type of stone from forming. Prevention, I want to focus on prevention. Um, we want to teach the patient prevention measures for renal stones. We want to make sure they have a high fluid intake that keeps the urine dilute and will help prevent the formation of stones, as well as dietary restrictions of calcium and purines. Um, the purines, we want to teach the patient to avoid organ meats, liver, kidneys, most meats, as well as sardines, scallops, and most of your seafoods can lead to high purines, which can lead to stones. We want to encourage the patient to have a regular exercise program. They may need medications to alter urine pH, such as the cranberry pills that they could take. And we want to implement measures to prevent UTIs. Signs and symptoms include severe pain. Stones that are small enough to move along will be very painful, causing a flank pain that radiates downward to the genitalia and inner thigh. And that can cause obstructions and swelling in the ureter, be very painful. Patient can become nauseous and vomiting. So nausea, vomiting, flank pain, flank radiating pain, actually. It's diagnosed with a urinalysis, a KUB, X-ray, and they may look at some serum lab levels of calcium, uric acid, and cysteine. Treatment, we want to flush the stone if possible, so the patient's going to get an IV. We're going to push fluids to try to help the stone flush through the system. We're going to implement pain management, opiates, NSAIDs, and antispasmodics. Implement antibiotics as needed. If there's an infectious process present, we can irrigate the urethral catheters if they are present per the physician's order. They may place a stent, depending on the variables of the situation, or they may do lithotripsy. And let's look at nursing care for the patient who has a renal stone. Acute pain is going to be an issue. So you're going to assess the characteristics of the pain. What is it on the pain scale? And then you're going to administer analgesics and antispasmodics as ordered by the physician. We can also teach the patient relaxation and imagery, back rubs, some of those types of interventions can help. Our nursing responsibilities, we want to implement pain management. We want to ensure a fluid intake of 3,000 to 4,000 mLs with a stone to flush it through. We want them to ambulate as early and as much as possible. For patients who are having lithotripsy, they may also have corticosteroids, calcium channel blockers, or alpha agonist, percussion, diuresis, inversion therapy. If a patient has to have a cystoscopy, we want to make sure we're monitoring for infection post-procedure. And we want to implement assessment for any changes in urinary output, characteristics of the urine. Does the patient have any risk factors or history, or any other assessment data that would be pertinent to stone formation? And we want to strain all urine. We can actually get a stone fragment and send it off. Your book talks about common catheters and tube care for urologic disorders. And this is on page 796, table 34.3. And you look over the different types of catheters. And I'm going to move on to trauma of the kidney, ureters, and bladder. So let's talk quickly about trauma. Kidneys and ureters can experience blunt trauma, motor vehicle accidents, sports or occupational accidents, any penetrating injuries, and urethral trauma, minor contusions. They can have severe hemorrhage and hypovolemic shock with this type of injury. For the bladder, it's usually a violent blow or a crushing injury. The bladder can become perforated or rupture, and the bladder can have trauma, and the patient experience fullness. Signs and symptoms. When the injury has occurred to the kidneys or ureters, there could be a massive hemorrhage present. You may see retroperitoneal bleeding, the Gray-Turner sign, hematuria, abdominal flank pain, and possibly enlarged mass on palpation. For bladder signs and symptoms, painful hematuria or the inability to void, marked with tenderness and spasms in the suprapubic region, and you may palpate a large mass. For diagnosis, the patient is going to have urinalysis. They may have an H&H and electrolytes, looking at kidney function, abundant creatinine, and then radiologic studies to identify any abnormal anatomy that would indicate injury. For bladder, we would be monitoring, or we would use gross hematuria, suprapubic, I'll get it out in a minute, excuse me, suprapubic pain and difficulty voiding. They may do a retrograde or a CT cystography to get a diagnosis. Treatment for the kidneys and ureter, we're going to treat for bleeding. We're going to treat lacerations and contusions without renal function interruption. We're going to treat that with bed rest. If the patient has severe kidney damage, then they're probably going to have a nephrectomy, and we're going to implement the post-procedure, post-operative nursing responsibilities for a nephrectomy that we've already went over. For bladder, they will implement a suprapubic cystostomy. or that's a suprapubic catheter. Preoperative for nephrectomy, we're going to monitor for hypovolemic shock, cardiovascular changes, urinary output. We're going to assess for any flank mass. We're going to look for a Gray Turner sign. We're going to monitor urinary output. And again, postoperatively, let's go over these. You're going to assess the surgical incision, assess for any presence of drains or tubes that were inserted during the procedure. You want to focus on maintaining urine flow in the catheters and tubes, monitoring vital signs, noting any signs and symptoms of hemorrhage. You want to notify the physician. And then note that dressings over the surgical incision may be reinforced while ensuring that you don't dislodge any drains or tubes. I think we skipped one. But we have, this is the second round with these two post-operative slides. Be sure you're comfortable with implementing interventions for post-operative nephrectomy. We want to position the patient according to the physician's orders. You want to teach the patient about taking their pain meds and teaching turn, cough, deep breathing. We want to monitor the urinary output of the unaffected kidney as well as the affected kidney. You want to measure that and record it. And note that fluids may be restricted immediately after surgery, but will be gradually increased. That takes us to cancer. There are risk factors for cancer of the bladder. Smokers have a double the risk of developing this type of cancer. Urban living puts a higher risk. Occupational exposure to nitrates, dyes, rubber, or leather processing chemicals put you at a higher risk. And then bladder tumors. They are highly invasive and metastasize. Signs and symptoms include hematuria, frequency, urgency, dysuria. They may order a IVP or a cystoscopy or just do a biopsy of a tumor. On page 797, you have a complementary and alternative therapy for a healthy bladder. Basically, it talks about smoking cessation and including vegetables in your diet, such as cabbage and broccoli. Your book does go into surgeries for urinary diversion. There's many different types of surgeries for urinary diversion, minor and major surgeries. I'm not going to get into the different types of urinary diversions, but I want you to look them over in your book, and we're going to learn about ostomy care in our GI chapters. Because you would care for these stomas just as you would a colostomy, a bowel stoma. So that's what I will focus on is stoma care. Nursing management for your patient with bladder cancer. You want to clarify orders if there are orders for irrigation of the tubes, drains, or stomas. You want to observe for pain postoperatively. Monitor the abdomen to monitor rigidity in the abdomen. Monitor for fever and bleeding. Urine should never stop flowing regardless of the surgical procedure. So you want to monitor the output and color and characteristics. And then if a stoma is present, you're going to assess and note if there's any skin irritation. So again, we will be going over stoma care in our GI chapters, and we will be tested in the GI section over stomach care. All right, that takes us to renal failure, and we're going to stop here.